It's good evening, everyone. First of all, I would like to thank you, the organizing committee, to allow me with this topic, which is very close to my heart. So, my topic of discussion today is primary immune deficiency in adult. We call things zebra. There is one tagline for primary immune deficiency. When you hear hoofbeats, you should think of zebra instead of horses. So, you need to think differently in whatever you are encountering in your everyday daily clinical life. So there might be some of you we are not agreeing with me, because whenever we heard the term primary immune deficiency, that's a defect in the immune system from the very beginning. The idea comes that that should be presented to the pediatrician. It's not a cup of tea for the adult physicians. But take it from me, you just be with me in another 15 minutes and you will agree with me that all of you have seen similar kind of cases in your lifetime, but you have not kept adult immune deficiency as a differential diagnosis of those cases. So what is actually primary immune deficiency? Is a group of disorder affecting the capability of fight against infections. And this includes defects in the T cell and B cell separately, or it can be a combined T and B cell defect. It can be a defect in the phagocytosis, complement defects, or defects in the cytokine and cytokine signaling pathways. If we look into the epidemiology from adult perspective, just look at the changes of how it has changes over years. Like if you look in the US population based data, it was 2.4 per 100,000 person years in the year of 1976 to 1980s, where it is jumped to 10.3 per 100,000 person years in 2001 to 2006. Moreover, if we look in the registry data, around only 5 to 10% of registry data was comprising of adult population, whereas the recent registry data of one of the largest registry of European Society Registry and Jeffrey Model Foundation Registry is now currently comprising of around 60 to 66% of adult populations. And not only that, around 8% of patients with primary immune deficiency are more than 65 years of age. And the oldest PID reported in registry, this is from the Australian registry, at the age of 96 years. So two learning points from this: it's not so rare disease, and it's not a diagnosis exclusively to the children. For recap, on a pie chart on the age distribution of the primary immune deficiency disorder, just look at that 40% of cases which is in between the 5 to 19 years age. So some of the patients must be coming to you. Next 20%, this is 20 to 39 years, that has to come to attend physician, and more than 40 years is another 60%. So there is a huge percentage of cases which primarily should present to a physician with different kind of recurrent infection. So what could be the scenarios behind this increasing number of adult primary immune deficiencies? So practically there could be two situations. Like first, this disease, some of the primary immune deficiency disease, there are more and more recognition. Now there are more than 400 of primary immune deficiency disorders. So more and more recognition of the entity, and some of this entity actually present in the late half of the life. And second thing, the disease that generally tend to be diagnosed in the early years, but some of them due to some minor mutations or minor modifications of those can present in the later age. Second possibility could be this is a poorly defined clinical and immunological phenotypes as a presenting features of primary immune deficiency, that possibly that PID is not considered or explored even ever for a single time. So the hallmark of immune deficiency is infection, there is no doubt, but is each and every infection is a primary immune deficiency? Definitely not. If we look into the Jeffrey Model Foundation's data, they have proposed 10 warning signs for when one should suspect a primary immune deficiency in pediatric populations. And the two or more of these warning signs at present, one should start thinking of primary immune deficiency in children. The similar thing has been proposed by the German Society for these adults with an acronym mnemonic of ELVIS, which stands for pathogen, like any infection of opportunistic pathogen like pneumocystis in an apparently healthy person, one should start thinking of primary immune deficiency. Second is localization, like any atypical location of any infection like brain abscess due to aspergillus, cerebral toxoplasmosis, pneumococcal arthritis, start thinking of primary immune deficiency disorder. Course, like an unusual course in terms of chronicity, recurrence, and unsatisfactory response to antibiotic therapy. We often encounter these things. Start thinking of if you are dealing with a primary immune deficiency disorder. I stands for intensity, like infections following an unusually severe course, and number of infections. Like for pediatrics, there's 8 minor and 2 major infections. But for rule of thumb, for the adult patient, 3 bacterial infections per year, each lasting over 4 weeks, should prompt further investigation for primary immune deficiency disorders. Is it just infection? Absolutely not. It's something beyond infections. So it can be present, the non-infectious manifestation, again proposed by the German society, this mnemonic of Garfield. It stands for granuloma, particularly in the lungs, lymph nodes, skin, and as well as other organs. The autoimmunity can be one of the presentation for the primary immune deficiency disorder, periodic fever, and hemophagocytosis. Eczema, lymphoproliferative disorder, and inflammatory bowel disease. Like it's early onset inflammatory bowel disease, atypical presentation, refractory therapy. Start thinking of whether you are dealing with a primary immune deficiency disorder. So primary immune deficiency is not just an immune deficiency, it's a state of immune dysregulation, which comprise of infection, autoimmunity, autoinflammatory, malignancy, and allergies. So what should be the clinical approach when you are suspecting in a patient with primary immune deficiency disorder? So there are 4 main headings, like age of onset can give a very important clue what kind of primary immune deficiency disorder you are dealing with. Family history, pattern of infection, and organ system involvement. Like age of onset, there can be the, like as I discussed previously, it can be due to T cell, B cell complements, granulocyte defects. T cell primarily presents at very early age, but rest of the thing can present at adult. B cell defect can present at adulthood. Complement can present at any age. Granulocytic defect can present at any age. So if we look at this is the x-axis comprised of age in years. So starts with 10, 20, 30, 48, and these are the name of the disease. Like the upper part of the disease, which is PID, that classically present in adulthood. These are the PIDs which classically present in adulthood, which comprise of one of them is CVID, which stands for common variable immune deficiency disorder, is one of the commonest primary immune deficiency disorder in adult. Other than late onset combined immune deficiency, data2 deficiency, and good syndrome, just look at the age of the onset of the good syndrome. This is beyond 40. Is the mean age of 50 to 60 is the mean age of presentation of good syndrome for as a primary immune deficiency disorder. This is Indian data published from PGMA Chandigarh, my previous institute. So if you look in the distribution of the different kind of primary immune deficiency, of 153 cases, majority of the cases are antibody deficiency cases. And as I described earlier, most of the antibody deficiency cases have a propensity to develop in the later age, like 20, 30, 40 years of age, and that they will primarily present to the adult physicians. Family history, how it's important, like there are most of the primary immune deficiency are genetically inheritance, like this can be either X-linked inheritance or autosomal recessive. So a detailed genetic 3-generation pedigree is very important whenever you are suspecting a primary immune deficiency disorder, or whenever you are dealing with some kind of unusual infections or with unusual complications. Also, the pattern of infection can give you an important clue, like B cell defects usually present with recurrent sinopulmonary infections that along with this pneumocystis, H. influenza, and Neisseria. Phagocytis is primarily present with abscess, pulmonary abscess, or lung abscess, liver abscess, severe systemic infections, and their defect in gram-negative or catalase positive infections are more common with this, the phagocytic defects. Whereas the T cell defects are primarily present with respiratory GI, and the T cell defects usually present at early age of the onset, unless it is a late onset combined immune deficiency. Physical examination also can give you some clues. Like of the late onset bronchiectasis, we often encountered adult patients with bronchiectasis. We don't know what is the cause behind. The patient having repeated history of cough with productive sputum. We are giving repeated course of antibiotics. Why we don't know whether possibly we are dealing with a primary immune deficiency disorder, that is CVID, which can present with a bronchiectasis. Next, I will go through 4 case scenarios because constraint of time, it's very difficult to go through all, touch upon all the clinical possibilities. Like this 6-year-old boy having recurrent neck swelling from very early infancy and had like 3 times of incision and drainage till now. This time presented again staph skin abscesses on the arm, recurring again drainage and IV antibiotics. Patient also in history of pneumonia due to nocardia 1 year ago, and elder brother also in history of recurrent skin abscess, serratia osteomyelitis. Two elder sisters presently those are healthy. Based on the clinical history, what arm of the immune system would you like to suspect impaired? It's nothing like if you have a recurrent skin abscesses, pneumonia, osteomyelitis, and two male siblings, defect in the phagocytic arm, and this is an X-linked inheritance. So, what is the most likely diagnosis in this? This is known as chronic granulomatous disease, and this is based on the family history. It's an X-linked chronic granulomatous disease. What is then actually chronic granulomatous disease? It's a phagocytic defect usually present infancy to late adulthood, and the problem is they're unable to kill the catalyst positive organisms. It can be due to X-linked or autosomal recessive. The median age though is 2.5 to 3 years, but autosomal recessive cases are milder, and that is the main bulk of presentation during the adulthood. And sometimes delayed diagnosis due to use of protein antimicrobials and granuloma formation and inflammatory process is a hallmark of chronic granulomatous disease. By name, it's obvious. It's a chronic granulomatous disease. What are the other clinical clues? Like if you are facing a recurrent, someone having recurrent pneumonia, pulmonologists call it encapsulated pneumonia, non-resolving pneumonia, or fungal pneumonia, lymphadenitis without any etiology, and hepatic liver abscess. If any liver abscess is very difficult to treatment, very resistant to treatment, requiring surgery, multiple course of antibiotics, think of chronic granulomatous disease. You're most likely dealing with a patient with chronic granulomatous disease. Osteomyelitis at multiple sites, perianal abscess, lung abscess, and empyema, and other clues for chronic granulomatous disease. The pathogens which are more commonly associated with staph, serratia, Burkholderia, Aspergillus candida, and nocardia. The second case is a 27-year-old female. She had a 6 sinus infections and 2 pneumonias in last 2 years, and last episode of pneumonia requiring treatment in the hospital with IV antibiotic. We often get this kind of patients. Healthy without infection until 5 years ago, and he has a past history of ITP. But currently she is not on any steroid or other immunosuppressive therapy, and there is a significant weight loss. So if we look into the pattern of infection in recurrent sinopulmonary infections suggest primary antibody deficiency, and one should send for immunoglobulin profile. This is a very simple test available everywhere. The B cell subtypes are difficult, but whenever you are suspecting someone suffering from primary antibody deficiency, just check one immunoglobulin profile, IgG, M, and A. There's a very simple test available everywhere. Just simple test can save this life. So the laboratory investigation will reveal panhypogammaglobulinemia and flow cytometry. That's B cell subset analysis will show the normal B cell. So this is more of a functional defect of B cell in the process of immunoglobulin production, and so most likely this is a case of common variable immune deficiency. This hallmark is hypogammaglobulinemia with a phenotypically normal B cell. Is presentation is a later age of onset, the second and third decade of onset, and usually latency of 4 years between the initial manifestation and fast diagnosis because of rampant use of antibiotics, and we often don't think of primary immune deficiency in these settings. And this is the commonest form of symptomatic immune deficiency in adult. If you look up asymptomatic, like IgA deficiency is the commonest, but if you call for the symptomatic primary immune deficiency disorder, CVID is the commonest primary immune deficiency disorder, and it's equally present in men and women both. So recurrent infection and sometimes unusual recurrent pulmonary infection. Sometimes these patients also can have granulomatous disease like 8 to 20%, and autoimmunity like this patient has an history of ITP. So autoimmunity can be in presentation around 25 to 30% case of CVID. And GI disease, GI colitis, lymphoid hyperplasia, and increased risk of malignancy. Other than lymphoma is the most common. GI malignancy is one of the very important clue that patient can have a CVID. That immune deficiency can lead to development of the H. pylori infection, and that resistant H. pylori infection that cannot be cleared can lead to development of the GI malignancy. Third case is a 14-year-old boy. He has history of consanguinity in the family, fever with headache for 1 month, CSF showed TBM. started on ADD after 3 weeks, readmitted with seizures. So neuroimaging basal exudates, communicating hydrocephalus, deficiency, CSF, loads of epigenetics but positive for MTP, but with resistance. We often encounter this kind of cases. So, like post-op, there is another infarct, and drugs in pattern again come ex-year tuberculosis, continue to deteriorate despite ATD based on the sensitivity pattern. So if there is history of consanguinity, if you're dealing with a primary XDR and difficult to treat TB, think of MSMD, Mendelian susceptibility to mycobacterial disease. So this is a disease which causes genetic mutation of those 5 genes are due to autosomal and 1 gene is due to X-linked, and these are basically interferon gamma related genes which mainly involved in the pathogenesis of the tuberculosis. So there is hamper in the interferon gamma pathway, and that leads to this kind of uncontrolled severe tuberculosis infection. Other than tuberculosis, they can present with disseminated basidiosis, though that will usually present in the pediatric age group. NTM infection and salmonellosis, recurrent refractory salmonellosis can be a very important clue. Salmonella osteomyelitis can be a very important clue for whether you are dealing with a case of Mendelian susceptibility of mycobacterial disease. This is data recently published in February for Indian data of 55 patients of MSMD. Just look, around 4% patients present were at the age more than 15 years. And the highest age was 25 years, and she presented with recurrent salmonella infection, nothing else. And this could be varied presentation starting from skin manifestation, CNS manifestation, osteomyelitis, GI involvement, lymph node, lung, and multisystem in many other. If you look the spectrum of infection starting from salmonella, which is very, very important clue for an MSMD. Other than that, CMV, Candida, staph, all these sets of infection can be a part of presentation of Mendelian susceptibility of the mycobacterial disease. The last case is of a 75-year-old man. So there is nothing wrong, like a 75-year-old man who got hospitalized with severe dehydration, secondary to 2 weeks history and non-bloody diarrhea and refractory to antimotility. Fine, this is a very common situation. But he had numerous primary care office visits and hospital admissions over the period of last 3 years. So 3 years when they started at the age of 72 years. But he is quite old. We know age could be one of the cause of immune deficiency. So should we start thinking of this kind of presentation as a primary immune deficiency at the age of someone presenting at 75? Possibly not in each and every cases, but we cannot ignore like this recent onset of rape.
Please wind up, Dr. Chattopadhyay. We are running short of time. Yeah.
So this was like the CT showed the mediastinal mass, and FNAC showed the thymoma. This is known as Good syndrome with the thymoma and hypogammaglobulinemia. This is known as Good syndrome. And if you treat these patients with immunoglobulin, you can change the course of their life. So take home messages: suspect PID. They are not that rare. Family history is extremely important. Pattern of infection and specific pathogen help to classify the PID, and careful history of and investigation like complete hemogram, platelet size. Systematic approach will help. So it is just not an infection. If it is a severe, it is persistent, it is unusual, recurrent, or runs in family, think of primary immune deficiency. Think zebra. If you don't suspect, you cannot detect it. Thank you.